are you?
Hello, Shirin. How are you?
Fine, fine.
I'm fine too. Okay, now we are waiting for the rest people who will join us. So, but we can start like we are glad to welcome you to our today's webinar. My name is Evgenia and I am representative of Bio3 Implants GmbH. If you have any questions or any suggestions during the webinar about our systems or topics which you want to see in our future webinars, you can write to us in the chat. We will contact you.
Yes, it's very good.
Yes, and I'm pleased to introduce to our lecturer, Dr. Shirin Farhat. Specialist in implantology and periodontology, Dr. Shirin has a European Master in Oral Implantology from Spain. Dr. Farhat is our successful Bio3 implants partner and already uses Bio3 implants in practice. Dr. Shirin Farhat, she is a scientific director of periodontics course at the EAOE and ADS, continuing education dental schools in France, and gives advanced courses on soft tissues grafting, techniques using alloderms and connective tissue graft, implant in the aesthetic zones, complication and management of failures, sinus lift, and basic periodontology. So, yes, Dr. Shirin, so continue, please.
Okay. Wait, Eugenia, wait, because now I have two laptops. So, so Eugenia?
Yes.
You open for everybody or not yet?
Yes. Now there will just we are open for everybody, of course.
Okay, 1 second. I'm just trying to open here the presentation. So, hello everybody. I'm glad to be here with you in this webinar about sinus lift procedures. Thank you, Bio3, for inviting me and hosting such scientific meetings. So, I'm not going to introduce myself after this introduction. Instead, I would like to have a few words about our host. Bio3 unites professionals. And today's webinar is a good confirmation of this. I see us already gathered today, people from many countries, and we also expect our colleagues to be in touch. I had the opportunity to discover the brand in the IDS in Cologne, and then I went in a visit to their factory in Germany. So I consider myself lucky to make this discovery at IDS that leads me to the use of Bio3 implant, who has a lifetime warranty, a high survival rate, and a super tight conical connection. I had no worries about bacteria penetration and later periimplantitis. I can perform with Bio3 system one-step implantation or immediate loading, so it suits me whatever was the difficulties in the clinical cases I had. And allows me to place both below cortical layer or above bone layer, depending on the clinical case. Also, the Bio3 system, we have the possibility to have guided surgery, which is follow the wave of technology. During the webinar, you may have questions. Please write them in the chat, and at the end of the lecture, I'll try to answer the maximum of questions. Now, I'm going to share my screen, so we can start our webinar. Wait a second. Just a few seconds, and we can
no problem.
So our subject today is sinus lift procedure, the state of knowledge. and we are going to talk about many techniques and to make it clear for everybody. Okay. Okay, so today we are going to talk about a very nice technique to vertically improve the bone height in the posterior maxilla, which is the sinus grafting procedures. And we want to focus on clinical aspects and on scientific aspects, and also to make some techniques a little bit more clear to use it for the daily practice. And today, of course, because the sinus cavity is an area where we really like to use bone substitute materials, we will focus on different bone substitute materials. So, what happens after a tooth extraction? Of course, we know that we see dimensionally rich alterations after tooth extraction. For example, in this mandible, we can identify two different parts. We have the basement of the mandible and also the alveolar process. So when we remove the tooth, we can see in this area that the functional loading on the alveolar process is missing. Therefore, we can see that in this area, the alveolar process is being absorbed. So with ongoing time after tooth extraction, we can see that this alveolar process will just disappear to the situation we just have the basement of the mandible. So where about the maxilla? The situation in the maxilla is quite comparable. So we see that the alveolar process is just remodeled again. So we have a vertical height loss and also a horizontal loss. But here another aspect is taking place. That also is the sinus cavity is expanding. That we have vertical resorption also from the side of the sinus. So it ends up to the K-root classification number 5. We have just a very, very thin bone layer on the bottom of the sinus cavity, and that makes it quite hard to place implants with primary stability. We need the functional integration of the implant body, and we can see it here on this histological slide. So that we had a direct contact of vital bone matrix to the implant surface. That is guaranteeing the long-lasting stability and also the possibility to functionally load the implant to restore the patient's needs. So when we focus on this bone area, we can see that the bone consists of three different aspects of cells. On one side, we have the osteocytes, which are mainly placed inside their own lacuna. They are mature bones and they are connected to each other, so they are not producing the bone, but they are leading to the effect that we have a vital bone matrix that might adapt to different loading situations. On the other hand, we can see here is that we have some lining cells. It is called osteoblasts. Here is lining cells, and these osteoblasts are able to produce different collagen molecules, also glucoproteins that can be mineralized. So therefore, the osteoblasts are very interesting for us because they are producing cells. And then, on the other hand, we also have some osteoclasts, the bone resorbing cells. And depending on the loading situation, depending on the Wolff's law, or meaning that we have a steady state remodeling, depending on the loading of the bone, we see that we either have some bone acquisition or some bone resorption in different situations. So what do we know about the bone regeneration? We had thought 30 years ago that when we have a bone defect, the osteoblasts that applies here as lining cells are invading into the grafted area, starting to produce new bone. What we found out was that the osteoblasts are very highly differentiated cells. So therefore, they are not able to migrate. They lost the capacity of moving from one side to another. And so the mainly cells that are capable to produce bone are the stem cells. So bone precursor cells that are necessary for the bone regeneration, and we find these cells mainly in two different areas. One area is the stroma of the bone marrow that makes this bone very interesting for grafting procedures, because depending on the grafting technique, we can maintain these pre-osteoblasts surviving and start to produce new bone on the recipient side. On the other hand, what we also know is that when blood vessels are invading into the grafted area around these small blood vessels, we find a high concentration of undifferentiated progenitor cells. We call them the pericytes, and these pericytes are also able to differentiate into bone cells if they find a nice osteoconductive and nice osteoinductive matrix and osteoinductive stimulus, and then they are able to start to produce the new bone. So now we come back to the clinic. So we have different defect classifications describing different areas of the alveolar process of the mandible and the maxilla. And today we want to focus on the classification of the Varpana that was described in 2001. It shows that in some cases only the sinus is extended. Sometimes we see a vertically resolved crest or a horizontally resolved crest, and also a combination of both. And because we are talking about a non-aesthetic region mainly, we can see that sometimes we don't really need to reaugment the vertically resolved crest. So we can just place the implants a little bit more to the apical direction if we have enough bone in this region. For example, for a completely edentulous patient, we can maintain stability to support the prosthetic part by placing the implant in an apical position. So, in some of those cases, short implant seems to be the solution to avoid heavy surgery. But what do we know about those kind of implants? A multicentric retrospective study on 230 implants of 6 mm with SLA surface with follow-up for 6 years conclude that at the mandible and when implants are twinned by crowns, results are very predictable, but collected data insufficient to extrapolate those results to the maxilla. So, some historical aspects. The first sinus was performed by Hill-Tatum in 1977, and the first lateral approach that was published was performed by Peter Boyne in the year of 1980. So he inserted some autogenous bone underneath the Schneiderian membrane using a lateral approach. And interestingly, what he found out was that the entire bone that he grafted resolved completely again if no implants were placed. This is also based on the steady state of remodeling. So if you don't place implants, there's no functional loading on the bone. So the patient's own bone would just disappear again following the wall slope. So from 1988, different bone substitutes were grafted in the sinus and with different innovation techniques. It was found also that bone substitute materials are showing predictable results if grafted alone or in combination with autogenous bone. It took some more years, but then in a recently published study by Klein and Anawas, there was a systemic review about the comparability of autogenous bone and bone substitute materials. And they found that there is no difference between bone substitute materials and autogenous bone for the indication of sinus grafting procedures. So today we can say that we can obtain the same results for the use of autogenous bone or bone substitute material, with the side effect that, of course, we can take the bone substitute material from the blister, whereas the autogenous bone needs to be harvested from another region. So, what sinus grafting techniques do we have? Of course, we have techniques using crestal approach, like the osteotome extension technique, where we need just a little bit of bone, and we're using the flexibility of bone based on the collagen content. Then we can use Summers technique, so it's called an internal membrane preparation, internal sinus lift by Summers technique, that we perform a preparation of the Schneiderian membrane and place some bone graft material underneath this membrane through this crestal approach. Then different aspects of it using a balloon lift, hydro lift, and so on. Then, of course, the lateral window approach with 1 or 2 stage procedures with and without implant placement. Here, the historical threshold is about 5 millimeters. So, when I learned placing implants, I was told if it's less than 5 millimeters, you have to do a second stage surgery to place the implants. Of course, implant shapes have changed. Also, the implant surfaces have changed. So we can guarantee, so if we can guarantee a primary stability of the implant, we can easily place an implant also in 4 or 3 millimeter remaining bone. The only important aspect is to make sure that we have a primary stability. And then if we have a combined defect, a horizontal defect, for example, and a vertical defect, we can combine it with further augmentations. So here we have a clinical case. There is a panoramic X-ray that we have a vertical ridge resorption combined with sinus expansion. And I think here I'm not at, have just to change the PowerPoint because I have not here the good PowerPoint. Second, I have to change. Okay. Not the good one. But here. So I was on the slide number 14, and I can go back here. Start. So. Sorry for this inconvenience, but I was not on the right presentation, and now we come back to this slide. For example, we can see here in a panoramic X-ray that we have a vertical ridge resorption combined to sinus expansion, and here. So it's moving. I don't have the hand on it. What's happening? Just Eugenia, are you using my hand?
Yes, Shireen. I see. Maybe you put some slideshow, and we cannot see your on the video.
I thought it was you who's using have the hand on my laptop. Wait a second. I will be back to that slide number 15, and
No problem. No problem. Okay. I think everybody understand it. It's normal. Okay. No worry.
Here, from this slide.
Maybe someone have some questions. Please write on the chat, and at the end of the lecture we will discuss this. All interesting. Next webinar, maybe you have some wishes for the topics for the future webinars. Maybe something like that.
Yeah. So. Now again, sorry again. So here we can see we opened the flap and we did the lateral window. We can see that the Schneiderian membrane.
Shireen, yes. I'm so sorry. Kindly raise your voice. They ask some Mr. Heidi. Yes.
Yes.
Okay. Thank you.
So, you want me to answer now, or I can continue?
Yes. Continue. But ask about some microphone. Do you have? Okay. Continue as it is.
Okay. So you are hearing me good, or there's a problem?
I can hear you. I can hear you very well, but someone's asked about. Okay, it's okay. The voice not so clear. Sharif Shaheen told us.
Okay, I'll continue. Okay. So here we raised the flap and we did the lateral window, and we can see that the Schneiderian membrane at this stage is still intact. Then we have to be very careful while elevating the sinus. problem. While elevating the sinus membrane using specific instruments to avoid any perforation. And here we have the bone substitute we are going to use. In this case, we chose Bio3 from Geistlich, which means xenograft.
Yes, Shireen, yes, please, not easy to hear. They think that you're far from microphone. Please make close your microphone.
Using the microphone of, okay, okay, I'll make it here. Now it's better?
I think it's better. Okay, thank you.
Okay, so we can
continue.
It's better. Okay, so I'm going to raise my voice also. No problem. Okay, so we can see just after the sinus grafting, we use a membrane to cover the lateral window to avoid fibrous encapsulation. What happens when the this is what happened when the periosteum is in direct contact with the grafted area. So here the membrane is used as a barrier also for the GBR that we need to regenerate in the ridge. So here at the end of the bone grafting procedure and membrane fixation with pins, we can see the form of the regeneration area well embedded with bone. And at the end of the surgery, we can notice that there is no stress upon the flap and a primary wound closure took place. On the other hand, the panoramic X-ray shows the dumb aspects of the grafted material beneath the membrane, so the sinus at this stage is clear. Here, when we come back to open the regeneration, the site of regeneration 6 months after, we had the re-entry to the site. And we can notice that the huge amount of newly bone formation that made our implant preparation and implant placement very easy. And when it comes to the sinus lift, we can see that here in the panoramic view, we can see the success of the procedure. Think that we can confirm by doing the CBCT, and here we can approve with no doubt the success of our bone grafting in the sinus. So what is the Crestel approach? So since 2015, technical progress, robotics, and industry contribution allowed us to get closer to the minimally invasive concept. This secured Crestel approach can reduce the use of the lateral window. So let's define the limits and the indication of this route. For advantages of the Crestel approach is that there is less fear, less invasive, low morbidity, immediate implantation, shorter intervention, and new secured methods. But there's also limitations. The limitations we have for this procedure is that it is a blinded surgery. We cannot control, we cannot see what are we doing. Lacerations and perforations are often unnoticed. Infectious risk is quite comparable to lateral approach. Patients relate and talk about an osteotome bad experience. Rare dizziness are 3%. And we can also notice sometimes contraction and muscle spasm as a consequence of the shock. So the osteotome technique is used when bone gain needed is less than 3 millimeters. And it is a very simple technique. For example, in this case, with a remaining bone height of about 8 millimeters, we wanted to place an implant with 10 millimeters. And what we see here is that we have enough bone to place the implant with a predictable primary stability, of course. What we do is that we perform the preparation of the implant cavity, and then before placing the implant, we are using some flat osteotome, and with some hammering technique, we can expand the sinus floor a little bit more to the apical part, and then placing the implant. So the idea is to use the flexibility of the bone. And we can see it quite easily on the post-operative X-ray. Of course, course, the patients don't like it that much because of this intensive hammering, but you can see it in that region, that the flexibility of the bone and the effect that we have expanded the bone more to the apical part. There is no need for application of bone substitute materials underneath the membrane, that we can just place the implant, leave the gap, fill with blood, and we can expect that in this area we will see some bone formation. Another technique that can be used for a very low trauma sinus floor preparation is the Summers technique. Summers technique means that we perform a quite comparable technique like the osteotomy technique, but then at the end of lifting, we can put some, we have to prepare the Schneiderian membrane and put some bone substitute. Therefore, we are using two different types of osteotomes, a flat and a convex osteotomes, as we see here. And here also is an endoscopic view of for the membrane, Schneiderian membrane preparation. The problem is that sometimes you have a little perforation that can be unnoticed, but you can easily see that with some bone grafting material, we can place an implant in this region with the internal sinus grafting procedure. So the big advantage is that the swelling is less than with the lateral approach. We come to the most common approach to sinus lift, the lateral approach. I mentioned this already. There's no more recommendation. It is only depending on your implant system that you are using. So if you have to choose between 1 or 2 stage procedures, it depends on your system. As I said, I use Bio3 systems. So with Bio3 systems, I can place implant 3 or 4 millimeters with primary stability when I have only 3 or 4 millimeters bone height. So now I'm going to show you a video. It's a lateral approach video done by my partner in the European Dental School, Dr. George Khoury, who I have to thank because he allowed me to put the video. And he is my partner, as I said, in the European Dental School. And we work together. Some of cases I put are his cases. So thank you, George. Now I put the video. So here, the video, you can see George performing the lateral window with piezo surgery. So he used this insert of piezo like a C to shape, to draw the lateral window, and then when this is done and well-defined parts of the lateral window, then he will change the insert to use another one. Like here we can see that the lateral window is slightly moving, so he can pass to another one, another insert of piezo to make it easier to remove this part of the lateral window. Not moving yet. So here the video is about 5 or 6 minutes, but if you want, we can send it to you. It's a full surgery video with about 1 hour. Now we can see that the lateral window is moving. So we have to be very, very careful not to do any perforation to the membrane at this stage, because it's very dangerous at this stage. And we can see it's trying to make it free, to make the lateral window, the cortical free, and also he will preserve this part of the maxilla to place it at the end of the surgery and to cover the window with it. So we start to see the membrane. Now we will use specific instrumentation to elevate the membrane without doing any pressure on it. Instead, we have to be positioned and to make all our pressure on the bone and not on the membrane. We can see that the membrane is floating because the patient is not under general anesthesia. So he is breathing, and when he breathes, we can see the membrane moving. So now we will go far to get into the sinus, trying to elevate and to free the membrane, medially, distally, and inside also. So now it's starting to be free, as we can see. And it is always moving, which means there is no perforation, because when we have a perforation of the membrane, it won't be moving like that. Stop moving when you breathe. So right now, he's making sure that every part of the membrane is elevated. There's no any part missing, not elevated, especially at the angles, because the angles of the lateral window are very dangerous and can cause perforation of the membrane. I hope that quality of the video is good enough to see every step and part of this surgery. Now he decided to put the implants at the same time because he had I think 3 or 4 millimeters that can guarantee the primary stability. So here we can see he's preparing his site to put, I think, 2 implants, and then he will put the bone grafting material. When he will be finished with the preparation. We have to make sure to finish all the preparation before putting the grafting material, because once we put it, we cannot do any preparation, because with the water, with the flow, it can the particles will go everywhere. Now I think he's using the final trim. And here we go. He will start now grafting the sinus, elevating the membrane with the particles, with the bone substitutes. I think here he used an allogenic bone. I don't know what was the idea behind this decision, because I know that George doesn't like allogenic bone in the sinus lift procedure because of the resorbability of the allogenic bone graft. Now he puts the implant, and the surgery was done. At the end of the surgery, he will replace the bone block, the lateral window, to cover the lateral approach, and then the flap will be positioned as it has to be, and stitches are made. So now we will pass to another case where we have a vertical defect in the maxilla and also a horizontal defect in the mandible, as we already mentioned and as we see right here in the panoramic. And so when we use bone substitute material, it's recommended to use membranes. You can either use resorbable or non-resorbable membrane. What you see here is a pericardial membrane that is quite stable with a long-lasting barrier function. We use this membrane for all our augmentation when we use bone substitute materials because this long-lasting barrier function is leading to a very predictable outcome. So, do we need to cover the lateral window with a membrane? There's a nice publication by Wallace and co-workers who reviewed 43 studies about 6,500 implants, and what he did found out. He concluded that when we use membrane to cover the lateral sinus, we know that the implant survival rate, also the bone outcome, is significantly better than not using the membrane. So therefore, it's recommended today to use a membrane also on the lateral window approach. When we say that, we mean that if we don't, if we couldn't maintain the part of the lateral window intact, if we cannot collect this part, we have to use a membrane to cover the lateral window that we just made. Also, for German surgeons, there was a statement of the German Association of Dental Implantology, the PTI. They published by Professor Menachem again in 2005 that whatever indication when we use bone substitute material, we have to use a membrane to avoid a fibrous encapsulation of the grafted area and to avoid this negative outcome and to increase the predictability of the GBR. So, what bone substitute materials can be used in the sinus lift? There's many bone graft that we can use, many bone substitute materials. We have the xenogenic animal, so like Bio3, Cerebone. It is deproteinized bone matrix, mainly hydroxyapatite, and it is osteoconductive. We have also allogenic, so human, DFDBA, demineralized freeze-dried bone allograft, like, for example, Max Graft from models like Puros from Zimmer, and alloplastic synthetic materials like bone ceramic, Max Resor, and others. And when we look at the very old publication, we can see that the resorbability was asked a lot in the older publication, that the bone substitute material has to be resorbed very quickly and should be replaced quite early with the patient's own bone. On the other hand, what we saw specifically in this science and in order of lateral augmentation and for immediate implant placement is that a material that is resorbed very quickly has a very low volume stability sometimes. So we know from different studies about Bio3 that after 5 years and after 10 years and after 13 years, the material is still here and can be identified when we take a biopsy. So therefore, we can say that xenographic materials are almost not resorbable, but leaving also the effect that we have a very good volume stability when we use these materials. And we can easily see it as well when we look at these histological slides with some materials that are resorbable very quickly. There is, for example, resorption fast remodeling for autogenous bone and for allogenic bone, and for integration and controlled resorption for example, for biphasic bone substitute. And the integration, we see it here at the right, is common with xenograph material or xenogenic materials. So these xenogenic materials show a very, very good stability with time. And as we said, after 10 years of biopsy, we can still find some particles leading to the effect that these materials are showing this volume stability. And here also we have 2 biopsies from sinus lift made with Bio3 and Cerebone after 6 months post-op. We don't see any difference. So of course, the staining impression of these 2 materials is a little bit different. But we see a nice bone formation on both BioOS and cerebral particles 6 months after sinus elevation. So right here, now we are talking about xenogenic materials, which means hydroxyapatite coming bovine deproteinized matrix. And then we took again a biopsy of this patient who has the two sinus lift with cerebral and with BioOS. We can see that 4 months sinus floor and then grafted areas, and 6 months later also we have the material that is integrated and very stable, remains stable and for very long time. So when you see this graph, we notice that hydroxyapatite has a very long resorption time, whereas the other grafts and autografts, and also similar to calcium phosphate, is showing a quick resorption and a quick remodeling of this material. So the idea of the next generation of the synthetic materials is that we combine synthetic hydroxyapatite with some tricalcium phosphate. This is because we know that synthetic hydroxyapatite is showing a very good long-term stability. This is a sinus grafting after application of a synthetic hydroxyapatite. We see bone formation, but this bone formation is not in direct contact to the bone graft particles. Whereas when we compare with beta tricalcium phosphate, there's almost nothing left of this material, leading to the effect that we have in volume shrinkage. So therefore, the idea of this next generation is that we have osteoconductive material that is integrated very quickly like beta-tricalcium phosphate, but also having a long-lasting volume effect based on the delayed resorption of hydroxyapatite. So one of those materials provided by Hembotis is Maxrizor. It is consisting of 60% of hydroxyapatite and 40% of beta-tricalcium phosphate with a very high porosity. And this is another aspect. We have a very rough surface, and this rough surface is leading to the effect that we have a very early attachment of protein cells, and this makes the bone substitute will integrate very quickly and very easy. And for example, we have this situation where we have to do a documentation with bone substitute materials to use. So in this case, we wanted to reconstruct, and also the viral process in this vertical dimension needed to be reaugmented. What we decided to do is to make a lateral approach window, and to use, and this was done with piezo surgery. And we also made some bone regeneration with harvesting some bone, autogenous bone. This case, at the end of this case, we can see that inside the region was perfectly regenerated, as we see here, as we can see here. At the end of the surgery, we put the bone block, and we put some max resorb also. We just said that max resorb is beta-tricalcium phosphate 40% and 60% of hydroxyapatite. So we can be sure that there will be no quick resorption. And then we put membrane and we close. And then at the end of the surgery, we can see that we tried to make an guided bone regeneration using bone block plate and with max resorb, and the grafting of the vertical bone was constructional. Also across the application of a bone graft to make sure that that we will be at the end with perfectly dimensionally placed the implants. So we can pass to the complications and the bacteria that we can find in the region of sinus lift. So what bacteria and what antibiotics do we use? When we look at the bacterial spectrum, we will find Streptococcus bacteria, Staphylococcus. So they are sensitive for aminopenicillin with carbonic acid. So we're using 3 times 500 or 1,000 milligram per day. If the patient is showing some allergic to this kind of antibiotics, we have to choose. We have to go to choose another like clindamycin, and even more. Even if the infection is very pronounced, we can use cephalosporin third generation. Combined with metronidazole like flagyl. Perform sinus grafting procedure. The most important thing is that we have to start taking antibiotics one day prior to the surgery. This will guarantee to us that we will have the antibiotics in the vessels and in the blood flows, and that can give a very good result to avoid any infection during the procedure. So now we are sinus lift procedures, an overview of the current techniques. For more than 30 years, the maxillary sinus augmentation has been mainstay of implant-directed maxillary reconstruction, and it is very predictable. I want just to talk about a few words about the assessment and planning before sinus lift. And for this part, I'd like to start with, by reflecting one of the earlier references which came in the consensus conference in 1996 from the Academy of Posterior Integration. One of the fascinating things about consensus conferences is, as many of you will appreciate, there have been many consensus conferences on various aspects of implant dentistry over the years, the majority of which tend to conclude that there is a little consensus. However, the uniqueness thing about the consensus was, as you can see, and I quote here in red, the most significant finding was that sinus grafts should be considered a highly predictable and effective therapeutic modality. So here we have a situation in which there's already a strong consensus that sinus lifts are a safe and a predictable technique. But they are, of course, not without complication. And since the early 90s, right through to current time, we've seen numerous publications on concepts to do with complications associated with sinus augmentation. And this reference is a recent one from the Journal of Craniofacial Surgery, And you can see that they referred to complications, typically being perforation of the Schneiderian membrane, hemorrhage, infection, and sinusitis. So these are the most frequently encountered complications. And then Sarno's group pointed out to us also that when penetrating into the maxillary sinus, we have a problem, and this typically what we see happening when people try to get without doing sinus lifts, where they try to squeeze some short implants and to avoid beneath the Schneiderian membrane and trying to avoid a sinus lift. I doubt a very disconcerting experience. So there's definitely a place for sinus lift even in a world where short implants exist. Because of course, many sinuses are literally absent of bone beneath the sinus. And so even short implants cannot be placed. So these are the sorts of things that we're talking about. And so what you see here is an implant completely into the sinus. And in fact, if you look here, you can see there's little or no bone, and that's a very long implant. I suspect probably attempted to be placed using an internal sinus lift. And here's another example here at the right, over here where an implant has been placed and finds itself rattling around inside the sinus. And these are not uncommon findings. And they are, of course, quite stressing for the patient and involve a significant additional surgery to remove them. Given that many of those end up in the hands of ENT surgeons rather than maxillofacial surgeons, it doesn't give our profession particularly good reputation either. Okay, so let's focus a little bit on the complications. So that most common complications, which is principally what I want to concentrate on it won't surprise you to learn that this intraoperative complication is the perforation of the Schneiderian membrane. And in of itself, that may seem to be fairly innocuous complication, but as we see in this study by Moreno Vasquez from just a few years ago, while many of these do not show any connection to additional post-operative complications, a significant percentage, maybe as much as 15%, go on to develop additional complications such as wound infection, abscess, dehiscence, sinusitis, loss of graft, etc. So one shouldn't ignore perforation of the sinus membrane. Another study here by Nolan et al. From Journal of Oral and Maxillofacial Surgery shows that incidence of membrane collaboration might be as such 40%, and that certainly reflects a wide body of literature, although its inevitability related to experience and skill set graft failure rate, you will notice it's significantly lower, and of course this is good news to us. So, of course, our goal here is to try to assess our implant and our case prior to sinus graft to try to mitigate against or reduce the risk of perforation. And there are a checklist of things that one has to consider, which you see here before doing any sinus lift. So to start, we have to see it is a single chamber or multi-chamber, whether it is a large or a small sinus, wide or narrow, whether it has or it doesn't have a septa or septi, and also because of the presence of septum is usually influence the percentage of sinus perforation we've already mentioned. The thickness of the membrane, which is related to the percentage of sinus opacity, and we will look at an E and T classification. It's very simple. We will allow you to grade your sinus accordingly to the thickness of the buccal cortex and impact as potentially with the vessels that runs here, because if the vessels, if the maxillary, posterior maxillary artery is big and that we will have a bleeding, so we cannot see, the vision will be, we have an alteration of the vision, and if we cannot see, we cannot do our intervention as we have to do it, so the risk of perforation will be higher. And at the end, we have to see also the location of the zygomatic buttress because it also influences the risk of perforation. So with this assessment and planning for the sinus lift, I would like to close to finish our presentation, and I will be glad to answer for your questions. And just to know, this is a part of a course about sinus lift. What we mentioned here is only a resume of sinus lift, because speaking about a subject like that is huge, and It will take hours and hours. So now I'll be glad to answer your questions, and if you want, also you have our mail here. You can send us mails about questions or clinical cases, and we'll be glad also to answer you. So again, Eugenia from Bio3, thanks a lot for inviting us. Thanks for hosting this webinar, and I was pleased and honored by your invitation.
Yes, I'm grateful to Dr. Shireen for such an interesting lecture, and I'm sure that it was useful to many of your colleagues, since the exchange of the experience is always great. And it is a honor for us that great specialists from all of the world were with us today. So, Shireen, we have some questions. If you
I'm just going to I'm going to see here what do we have questions. Okay, at the beginning the microphone wasn't working apparently, so now I'm seeing that. Okay, so what else? Which membrane do you use to close the window? Okay. Usually, if we can maintain the window part when we perform the lateral window, it will be better to reposition this bone and to close the window with it. But sometimes when we perform the lateral window, we try to remove it, and we use the burr to create this window, so it won't last anything at the end. This time we can use a collagen membrane like iodide, or we don't need a pericardial membrane in those cases. We can use a collagen membrane like iodide, something that will resorb few. Let's say in 8 weeks or 3 months will be more than sufficient. So after, I see here there's some nice comments, very useful and interesting. I used the same bone. Can you tell us, please, about your failures during sinus lift procedures? Very well, thank you. Also, can you tell your pharmaceutical protocol before and after sinus lift? Okay, so about failures during sinus lift. Yes, of course we had failures. Implantologist who doesn't confirm having failures means that he didn't put implants, because dentist or dentist, specialist in perio and in implants. And in my private practice, I put about 400 to 800 implants per year. So I think Bio3, I know that because I use only Bio3 implants. And I used to do, and I always do, internal sinus lift, external or lateral approach sinus lift. And sometimes we face complications, sometimes we have infections, and sometimes when putting the implant, we close our eyes and the implant maybe go in the sinus. During my experience of sinus lift, it's been about 10 years doing sinus lift. I lost one implant in the sinus, and I was lucky that I did what I learned, and I took it out back without sending him to the ENT surgeons. But it was, I think, it was a mistake done by me, because I was not well experimented at the time, and there's no recommendation for sinus lift. I think it's a practitioner depending, and someone who has experience is not like someone who doesn't have experience. So I think to try or to start sinus lift, it would be better to start with 3-4 millimeters bone height needed with Summers technique, some internal sinus lift technique, and then progress with the experience and go for lateral sinus lift. About my pharmaceutical protocol. So before, yes, I give antibiotics. I give also augmentin or amoxicillin with clavulanic acid. If there's no allergy to this molecule, and I give 1 gram morning and 1 gram the night to be started 1 day before. And then we can, then after the surgery, I would like to maintain the antibiotics at least 8 days. At the end of this time, I will ask to see the patient and to verify that everything was good. And also, I give Solpred with the augmentin. It's cortisone, and I use it actually to free the osteum. Some practitioners use another drops that can do the same effect, but I'm using this, and this is one of the recommendations of the French Oral Society of Oral Surgery. So that's about this pharmaceutical protocol. Which methodic is your favorite? There's no favorite methodic, I think. I think it's case depending. What I think for me, sometimes I found that internal sinus lift is easier, and sometimes I found that no, lateral sinus lift is easier. Especially when we have the sinus. The sinus floor is not horizontal and somehow like that. I think in this case, even for one implant placement, one tooth placement, the internal sinus lift will be a little bit complicated. So what else? Do you have an experience of lateral sinus lift after radical sinusectomy? If patient had a sinusectomy in anamnesis, no, I didn't have any patient with a sinusectomy. And I think I've read one article about patients who had some surgeries or some failures in the sinus. In this case, what I read is about the bone substitute using after those complications. I read that it's better or it's recommended to use autogenic grafts in those cases because it will induce and will the predictability of the bone will be better if used or if autogenous bone graft is placed. So what else? I hope I didn't lost any question.
About membranes, I see a few questions.
Okay, which type of implants you recommend? Standard, SLA coated, or other? Nice question. Okay, I don't recommend anything. SLA coated has success. What I'm using is the Bio3. The Bio3 has the noble surface, and I'm not having any problem with it. Just one question, just one point to speaking about the SLA coated. In my personal experience with SLA active surface, not in my private clinic, but in the Lebanese university, because I'm also head of periodontology in the Lebanese university, head of clinic in periodontology. We had a lot of problem with SLA active, and the problem was not about the surface or the treatment of the surface, but it was about the stockage. So SLA active needed to be stocked in temperature, in certain temperature, without being under the sun and something like that. So we had a lot of problems and failures, but don't have anything to say about SLA active that is not good. I know that SLA, Bio3 have also SLA right now. I didn't when we switched to SLA, but I have no problem with the surface. I'm good. There's no failure or early failure with the system of Bio3. So I'm very satisfied with it. Do you combine BioOS with Autobone? And if yes, where you took Autobone from the patients? Okay, so this is a very, very interesting question. Why do we have to combine BioOS with Autobone, autogenous bone? We used to combine, and we always till now we combine this to get the collagen matrix from the autogenous bone. This is what Urban says, and many articles are published on that. Just a few words about this. You can find also collagen matrix in what we call BioOS collagen from diasttic. So I know that Dr. Khoury, George Khoury, done a lot of research and clinical cases, certain clinical cases on the use of this material, and he have a great results. So I think that now we are leaving this harvesting of autogenous bone because of the side effects of it, two side surgeries and everything like that. If we can replace it with something in the blister, it will be better for the patients and even for the practitioner. Okay, so what material do you prefer with the open sinus lifting technique? As we said, there is lots of material. What I can say that what I what I will not use in the sinus lift is allogenic bone substitute and the autogenic, because it's an over treatment, especially when we know that it will disappear, it will resorb very quickly. Also, beta-3 calcium phosphate on itself, without any combination or any addition, I will avoid it. So what I use right now is sometimes I use BioOS, which means xenogenic grafts. Sometimes I use now I'm going to use what we call biphasic. So it's beta-3 calcium phosphate with hydroxyapatite, and I think this combination is very good because it resolves the problem of resolvability of the beta-3 calcium phosphate, and at the same time it can maintain the volume of graft with it. So, which implant is better for sinus lift, progressive or advanced? Actually, and I think Eugenia will, if she opened the folders, she will find out that I only use progressive implants. I don't have anything bad about advanced implant, but when I started with the implants, Bio3 implants, I chose the progressive, and in my character, when I use something and I'm glad with it, I prefer not to change. So with progressive implants, I have no problem at all, and it's been 4 or 5 years I'm putting Bio3 implants progressive with no problems, so I will keep using the progressive implants. So what else? What is your attitude towards what? I don't know what you mean by chitinized materials. I don't know what you mean by that. I think there's one question I didn't see about. Do you use any Do you use any South Korean implants in your practice? Not by me. What I used to use before Bio3 implants, it was Zimmer. And since 4 or 5 years, I'm using only Bio3, as I mentioned. But in our university, in Lebanese university, we used to use some Korean implants like Megagen. I don't have any feedback about those implants because in our practice in the university, the perio department, we place implants, and then there's a prosthetic department who will find out if the implant success or failed. So I can't tell you anything about that. Do you use trauma in your practice? Yes, in the university also, not by me, but by my students in the Masters of Periodontology. Straumann is one of the biggest and from one of the premium implants in the world. We cannot say anything else about it. And what else? But Bio3 better. Yeah, for me, it's better. It's better. That's what I think. It's. I'm glad with Bio3, and I will continue with the system. And thank you a lot for the team of Bio3 because they answer our request. And now I'm trying to do a research about the outcome of BioLine, the aesthetic outcome of BioLine, what it gives to us plus that doesn't exist in other systems. And I think that the results I'm collecting right now is very, very encouraging. And when the publication is finished, I will give it to Bio3, and it will send it to all the users of Bio3 system. Your 3 advices for beginners. Okay, for beginners, I will give you the 3 advices that I had from my professor. So, first time doing sinus lifts, being assisted by someone who is experimented in the field. The second one, second advice is to go for it slowly, giving time to the experience to take place, which means starting by bone sinus lifting for 2-3 millimeters needed, not more than that, and then with time the experience will take place, and you can go for lateral sinus lift with 1 millimeter remaining bone height with no problems. Okay, so as you prefer advanced or progressive, yeah, I said I don't know. I let Bio3 answer this because I don't have any experience with advanced implants. I have good progressive Bio3 implants, and I'm so satisfied with it. If you perforate membrane, do you use PRF membrane? Yes, I use PRF membrane, but not because it is a membrane. Just to let you know, the PRF from Shukun will disappear and will resolve after 12 days. So if you count on it to maintain your bone graft particles underneath the perforation, underneath the Schneiderian membrane, you will face some complications later. Actually, I use it because the platelets inside the what you said, the PDGF and all growth factors that is inside the PRF will enhance the procedures of cicatrization, and not because of its quality as a membrane. And also, when I use PRF, I usually find that the wound healing is very good. The color of the gum is very pink, light pink, and not swelling. That's why when I have time, when I can, I always take blood from the patients and ask my assistant to make for me PRF, injected PRF or SPRF. I think it is good, and it gives a tip for our surgeries. Okay, so yes, Regina?
Yes, Shireen, thank you very much. If we are not answer all some questions, we will answer, okay? And maybe if you have some more questions, please write to us on our website. Maybe you can write also. We will contact with you who would like to try our system also, please write to us on the website info@bio3implants.com. And at this time we can still meet.
We can write here. We can write here in the conversation. You can write your the email of Bio3 info@bio3. So if they have questions, they will send it directly to your mail, and you will forward it to me, and I will be glad to answer for all questions to the Bio3 practitioners.
Yes, yes. At this time, we can still meet with you online, but sooner or later, we will definitely meet with you offline. We are glad to invite each of you to our factory. So, yes. So, ladies and gentlemen, thank you for your attention. Thank you for dear Dr. Shireen for your helpful lecture. I wish.
Lecture.
Yes, yes, I think that we will get some maybe wishes from our guests about future webinars. So we will arrange again one more, and with Dr. George Huri also in future. Yes.
Yes, of course. Of course.
If any questions?
I think here we have it's a thanks. There is a lot of thanks.
Yes, yes. Yes, we also thank you too much, and thank to all of our guests, and I wish you all a good day. So
right here. How much time do you wait until to finalize the treatment? Okay, it's a very nice question. Okay, so to finalize the treatment, it all depends on the case. Which means if you have 0 4 millimeters bone height remaining, and you are going to put an implant of 10 millimeters, which means we had elevated the sinus of 6 or 7 millimeters, we can go to put the implant at 5 months, I think. But sometimes when we have only 1 or 2 millimeters and that we elevated the sinus, we can open and we can try to put our implants at 4 months post-op, but do not put the healing abutment. This reopening or re-entry at 4 months is not to put the implant and to load the implant. In those cases, we reopen just to reactivate the bone remodeling. So we put implants. When preparing to putting the implants, the bone remodeling process will be reactivated. We put the implants, we cover the implants, and we come back 2 or 3 months later to open and do the second stage and then the impression. Okay, so I think now it's it was the last question. I think I don't know. It will be there any certificate from Bio3?
We can, of course.
And I will be glad to sign all the certificates, and I will be glad also if you need any information about our school, European Dental School. You have my contacts through Bio3, through Eugenia. She will give you my contact, and I will be glad to tell you about our courses, our master courses. Master courses are also in collaboration with Bio3.
Yes. Thank you very much.
You're welcome. Wishing you a good day, and thank you for your kind presentation, kind presence and kind registration for the webinar.
Yes, thank you, Shireen. Thank you very much, and thank you to all. So we can finish. Yes. Any questions? And thank you very much. Keep in touch. See you soon all.
Okay, bye-bye. Ciao.
Bye.